This is St. Vincent's Health Talk, a call-in medical talk show sponsored by St. Vincent's Health Services on WICC 600. Dr. Frank Schifo, an award-winning physician and noted family practitioner, is standing by to answer your healthcare questions and to share some of the latest news and developments in medicine. His guests include area physicians and healthcare professionals who are specialists in a wide variety of fields of interest to you and your family. Now here's your host, Dr. Frank Schifo.
Good evening, and welcome to this edition of St. Vincent's Health Talk. My guest this evening is an old friend of the show. That's Dr. Peter McAllister. Dr. McAllister is a board-certified neurologist with the Group Associated Neurologists of Southern Connecticut. And they have offices in Fairfield and in Milford. And Dr. McAllister has a particular interest in headaches. Patients who have suffered from headaches and seeing him know the passion he has for working with these patients. And we're talking about chronic pain, and sometimes headaches are chronic pain. And for some individuals, the relief provided is just huge. So I want to welcome Dr. McAllister back. Peter, thank you for coming down this evening.
Well, Frank, it's been a while, but it's always fun to be on this show, so thanks for having me.
Oh, it's my pleasure. And I thought the obvious here tonight is headaches. Let's talk about headaches. You are extremely well versed in the treatment of headaches. It is a subject that you've been, or a malady you've been treating for years, and you've made it your interest. And, as I said to you before we went on the air, I'd like to really present headache in a gradual severity of symptoms fashion. So I'd like to start out with the simple headache. Someone wakes up, have a headache, maybe allergy related, maybe, the way they slept, could be a multitude of things. Right. Let's talk about the simple, what I'll call the simple headache, which may not be simple.
You're right. There's very little that's really simple when you get down at the details when it comes to headache. But, you're right. So about 95% of this country, 95% of us have experienced a headache. And in medical jargon, those are generally what we call tension-type headaches. And we don't consider those a medical condition. That's part and parcel of life. Importantly, they're not debilitating or disabling. So you have a headache, it's kind of a mild, maybe moderate pain. You don't have any associated symptoms. You're not throwing up, you're not calling in sick to work. It's usually relieved with some over-the-counter medicines, some Tylenol, some Motrin, that sort of thing. So that's one group. And in fact, that's the largest group of headaches. But those people don't come to see me. They don't call in sick to work. If they're kids, they're not missing school. So the most common headache that is disabling, that'll send somebody in to see me, is migraine. And, migraine is overwhelmingly a condition of women, with about 18 to 20% of all women in this country having migraine, about 6% of all men. And when you do those numbers out, we're talking 36 million Americans in this country have migraine. So from a disease state perspective, that's more than diabetes and heart disease combined.
Okay. I'd like you to define for our listeners what constitutes a migraine headache. I still have limited patient interaction at our urgent care centers, and albeit limited, I will see the patient that comes in with a headache, and they'll tell me they have migraines, and I'll say, when were you diagnosed with migraines? What do you mean? I said, well, who told you? No one. I just know that I have migraine headaches. And, I find that somewhat interesting. So what really would be the definition of a migraine headache? I know there are several types. We can get into that, but let's just, what constitutes a migraine
So you're right.
headache?
A lot of people use the term migraine rather loosely. You could be sitting there with a very dull headache and no other symptoms talking about your migraine, and it's probably not. So here's the definition. There's actually a group of neurologists around the world, as you'd imagine, called the International Headache Society, and they came up with criteria and then tested out their hypotheses to make sure that everybody was on the same page. So what we're talking about is a moderate or mostly severe head pain. This isn't mild. It's usually, but not always, one-sided. Here's a bit of trivia for you. The word migraine is derived from the Latin meaning half a head, or hemicrania. So it's often one-sided. The important thing is there's associated symptoms. So you have to have some of these, and those include nausea, or actually throwing up, light sensitivity, or sound sensitivity. That is, you walk out to a bright room, your headache gets worse, you want to be in a dark room, you don't want to have a lot of noises. It can also comprise dizziness, mental slowness, fogginess, sometimes even numbness or weakness in the arms or legs. So that's what we're talking about. It lasts usually part of a day to 3 days. And again, it's a big disabling condition. There was a famous woman writer, and I'm blanking on her name, who said, the fact that migraine doesn't kill you is a bit of a mixed blessing. And, what she meant was, this thing really feels bad enough that it could do you in, but of course no one dies from it. What happens, though, is if you have migraine, particularly if you have frequent migraine, you're missing time from work, you're missing time from school if you're school age, you're going to emergency departments and walk-in medical centers. The healthcare costs of migraine are greater than a whole bunch of other diseases we know, such as asthma and, again, diabetes. So it's a sometimes underdiagnosed, often misdiagnosed malady, but it's not very hard to diagnose it, and there's no scans necessary. One doesn't need to get a CAT scan or an MRI, probably in 95% of these patients. We go right into treatment as soon as we establish the diagnosis.
And when we identify someone with a migraine, that's usually, I like the fact that you pointed that out. You don't need the CAT scan, you don't need the imaging study, the MRI. You're comfortable making a clinical diagnosis as a neurologist. And I think that's something that needs to be clear to our listeners.
Right. So, it's again, for a headache specialist and neurologist, this is what we do. Okay. So, as my wife would say, I'm not good at much, but I'm pretty good at migraine. And someone who comes into the practice, I would say 80-90% of them don't need a scan. And now, sometimes there are symptoms or signs that are a little alarming that might prompt us to get a scan. If someone's migraine causes a facial droop or a weakness in an arm or slurred speech, those all could be just migraine. In fact, most likely that's what it is. But those would prompt a scan to make sure we're not dealing with something like a stroke.
Yeah, I can appreciate that, and I think that the reassurance delivered by the neurologist, and if, as you say, there are any ophthalmologic associated conditions, you see an ophthalmologist and they're convinced that whatever happened was related to migraine. It's very reassuring to the patient.
Now, here's a couple of things that's migraine where everyone thinks it's not. If you have a lot of pressure, a socked-in feeling around your face, a nasal congestion, some tearing, the Mayo Clinic out in Minnesota actually did a study of people who had recurrent head and face pain with a socked-in sinusy feeling. So what did they call that headache? They called it sinus headache. Well, the study at the Mayo Clinic, actually, we scanned them and stuck probes up their nose and cameras and looked them over. And it turns out that about 85% of these people who have what they thought was recurrent sinus headache, it was migraine. So another one is people who think that they need their glasses adjusted. I see that because I take care of children, too. And the mom might say, well, we just need to adjust his prescription for his glasses. He's having headaches around his eyes. Almost never the case. There are headaches that are migraine that can occur in the back of the head and neck, and oftentimes people say, well, this must be a pinched nerve in my neck, or how could it possibly be a migraine? It's in the neck. Well, we have a medical term for that. It's called cervicogenic migraine, which is a migraine-type headache that begins in the head, neck, or even shoulder, radiates up and over, often on one side, landing around the forehead or an eye, and then having the nausea, the vomiting, the light and sound sensitivity. Those are all migraines, even though commonly those are misdiagnosed.
I'll be very transparent. About 2 years ago, I was doing the show on a Monday night, and halfway through the show, I had a visual field change. I felt like I was looking through a window that someone put a baseball through. I could see shards of glass. And I stopped the ED on the way home, got checked. Next day I went to the ophthalmologist, and he said, that's your migraine. And I had a history of him, and he took out a textbook and actually showed me what I visualized in the affected eye. So an awful lot, even as a physician, you can get a little bit concern?
Well, because it's very scary.
Sure.
I mean, if you're sitting there and all of a sudden you have a shimmering or shards of glass or sometimes an evolving black spot that goes from the right side to the left side,
Sure.
well, everyone thinks stroke. I have patients who are convinced that they have brain tumors, etc. This is scary stuff, but most of that is migraine. Now, that type of headache, the one that has a visual aura, we call it, or a scotoma, that is some shimmering lights, zigzags, etc., that's actually called classic migraine or migraine with aura, and that's the minority. It's about 25 or 30% of migraines have that visual stuff first. The majority just go right on to light and sound sensitivity. They throw up, their head hurts, they lay down in a dark room, and then what they do is they call in sick to work, or they can't go to school. 36 million Americans have migraine, so
Wow.
it's a big number.
36 million. I want you to hold that thought. When we come back, we'll talk more about migraines, perhaps talk about some of the prodrome symptoms that we can see, talk a little bit about heredity, familial predilection. Dr. McAllister is here to take your phone calls. If you have a question about headaches, he is the headache specialist. Call 203-333-9422 or 1-800-922-6060. We'll be back with more of St. Vincent's Health Talk, Dr. McAllister, and myself right after this.
The hands at St. Vincent's are special. They've lifted patients whose hearts are on the mend, reunited families, and given hope to those who had none before. And now, working with the minds at St. Vincent's, they're finding safer ways to repair ailing hearts, like pioneering new techniques in minimally invasive cardiac care, so these hands can touch your heart, while these minds develop ways to make it stronger. Find out what gentler hands and sharper minds can do for you at stvincents.org. The minds at St. Vincent's are extraordinary. They've found new paths into the heart that others have missed. And with the help of skilled hands, they've orchestrated a symphony of doctors to keep an inoperable heart beating. Together, they're innovating cardiac care, making us one of the area's safest hospitals. So these hands can continue to protect hearts, while these minds continue to inspire them. Find out what gentler hands and sharper minds can do for you at stvincents.org.
Bob's Buick GMC of Milford, the dealership that just wants to get you a loan.
If you're a responsible homeowner who's faithfully made your mortgage payments, you deserve thanks for doing the right thing. And I'd like to tell you about a powerful financial tool that rewards your responsibility. Hi, I'm Jay Farner, president of Quicken Loans, and the tool that I'm talking about is the Home Affordable Refinance Program, or HARP. HARP is designed to help you lower your mortgage payments. It's for responsible homeowners who are current on their payments, but due to the housing market may have little or no equity left in their home. And even if you were unable to get a HARP loan in the past, new guidelines mean that now you may be eligible. Over 2.5 million homeowners have already taken advantage of HARP and are saving an average of $250 a month. If you're one of the millions yet to take advantage, call us today at 800-QUICKEN. To learn more, call Quicken Loans today at 800-QUICKEN or go to quickenloans.com. That number again is 800-QUICKEN.
Important terms and conditions apply. Call us for cost information. Equal housing lender. Licensed in all 50 states. NMLS number 3030.
iHeartRadio is happening around the world. Listen to your favorite station when you travel. Plus, discover over 1,500 of the best stations right from the free iHeartRadio app. iHeartRadio is designed for your iPhone, iPad, Android, and more. Don't miss a beat when you're away. With just a touch, you're listening to the programming you love. Find out why iHeartRadio has nearly 200 million downloads. Grab iHeartRadio free where you download apps or get started at iHeartRadio.com.
Remember, you listen to WICC today.
Good evening and welcome back to this edition of St. Vincent's Health Talk. For those of you who have joined us at the top of the hour, you'll know that our guest is Dr. Peter McAllister. Dr. McAllister is a board-certified neurologist and a headache specialist. He's with Associated Neurologists of Southern Connecticut. And if you want to get a pencil and paper, I'm going to be giving you some information, his telephone number and his email address. Before we went to break, Peter, we were talking about migraine. You talked about the classic migraine. And off air, we were talking about some of the presentations, some of the symptoms one can see, some of the prodromes. You talked about the light. Remember that being a board question, scintillating scotoma. And I'd like to talk a little bit about that because maybe we can allay some of the fears. And obviously, please keep in mind we're talking in generalities tonight, so we're not diagnosing you. We're just sharing some general thoughts about headaches, something that may give you some insight. And again, our telephone number is 203-333-9422 or 1-800-922-6060. So, Peter, talk a little bit more about some of the symptoms one can experience before that.
Right. So, you know, it's interesting. We call it migraine. I'll tell you, years ago, and I'm sure you'll remember this, we called it migraine headache. But actually, we dropped the headache part because we know there's a lot more to it than just the headache, right? So we think of migraine. So now we also know that this is a neurological disorder. That is, this is a brain condition. It has very little to do with blood vessels. It's brain tissue being activated improperly. So it's like a play with 4 or 5 acts. Often it begins with a prodrome. So migraine sufferers know something's not right. Their concentration is a bit off. They yawn. They go to the bathroom more. They just feel vaguely not right. Following this, if they're going to get the visual, what you said, scintillating scotoma, that is the shimmering lights, etc. Remember, the minority have that, but when they have it, it's impressive. It then often progresses to the head pain, throbbing, often one-sided and severe. But I must tell you, there's a small group of people who have migraine without any head pain at all. And that's interesting. You feel crummy, you get the visual stuff, and then it kind of goes away. Well, most of us get the migraine pain, and then that can last for hours or days unless we take some medicines, which we'll talk about, to knock it out. Following that, you have the washed up, feeling lousy, kind of wet dish rag feeling, and that can last another day or two. Now, you could imagine if you have 2 or 3 or 4 of these a year, it's bad enough. But some of the patients in my practice, the really bad off ones, they're having 8, 10, 12, 20 days where they're going from feeling crummy, head pain, feeling crummy again, and then cycling through it. And so my job is to make sure that the diagnosis is right and then treat them. And the treatment really is a holistic approach. The last thing you do is just throw pills at these people, particularly those who are having chronic migraine. So chronic migraine, I should get into, is different from the infrequent ones and is defined as 15 or more headache days a month. So the newer studies on migraine suggest that that is really a different animal. People who are having nearly every day of the month migraines go to emergency departments far more. They drive up healthcare costs. They wind up losing their job. It affects their family. It affects their home life. It affects their social life. So those people, you think of any disease, think of asthma, think of diabetes. There's always the very mild cases, the moderate, and the severe ones. Well, in my practice, chronic migraine is my really bad headache syndrome.
Those patients oftentimes will struggle for years, perhaps seeking episodic care in an emergency room, in an urgent care center. And it usually, in my experience, isn't until they've really established themselves with a primary care physician who recognizes the potential need for a workup. This could be migrainous in nature, and sends them off to a specialist like yourself. Would you agree that that's unfortunately many times the case?
You're absolutely right, Frank. So because we all have had a headache in our lives, 90+% of us, those who are suffering sometimes don't even have the diagnosis made. And because there are over-the-counter medications that can dull some of the pain a bit, these people try to function and try to struggle through, and it may not even occur to them that they have something that can be treated in a much more rational kind of medical and scientific way. There are some doctors who are very well versed in migraine and some who aren't, and particularly those who have migraine. I have a lot of, and again, this is not exclusively but overwhelmingly a disease of young and middle-aged women. And I have found that the women primary care doctors seem to be very in tune to this, and they say, I know exactly what you have because I have it too. Go see the headache specialist. So you're right. It is underdiagnosed and misdiagnosed, but it can be treated if you go to the right person. Now,
there are certain triggers for certain people for migraine. I know I have certain triggers. Patients have, I'm certain, shared many triggers with you. Can we use a broad brushstroke to share some of those?
Sure. So migraine, first of all, is strongly genetic. So 70% of migraine sufferers have a family, relative, parent, and aunt, etc., who has had it. So if you're genetically wired for this medical condition, migraine, The next question is, what brings it on? And what's the difference between one headache every other month and 20 headaches per month? And we have really good data on that. So the number one trigger in a migraine sufferer for having their next headache and the one after that is stress. Stress is the number one. So one of the things we do at the Headache Center, because I have neuropsychologists and I have counselor therapists and acupuncture and massage, etc., is we go after the stress. So that's number one. There are a whole host of other common triggers, and I'll just list a few. Lack of sleep. All right? This is Fairfield County. Everybody's running around like a chicken with their head cut off, not getting enough sleep. Either they're working hard, taking the train to the city and back, or they're taking care of the kids and don't have a moment for themselves until midnight. So lack of sleep is also a trigger. In fact, in our teenagers, even sleeping in on the weekend. So they, as I joke with my daughter, up at the crack of noon, kids who sleep in too late can also trigger their migraine. So sleep is a biggie. Foods, about 10% of migraine sufferers have an identifiable trigger. That is, a hot dog causes a headache, or coffee, a headache, red wine, a headache, etc.
Preservatives.
What's that? MSG, if you go out for Chinese food,
Sure.
etc. So nuts, aged cheeses, these are common ones.
Yeah.
At the Headache Center, we have a whole list, and we say these don't apply to you. These apply to, the population. See if some of these trigger your headaches. These are the big offenders, and then we start eliminating them.
It's interesting. I remember a patient who would tell me that when he drank his own homemade wine or his brother's homemade wine, he was fine. But if he went out and had a bottle of wine, he always had a headache.
Right. I have people who swear that the sulfites, which is a preservative in wines you buy in the wine store, can cause it. And there is some data to suggest that. Another one is dehydration, commonly missed. So
I'm aware of that. That you're very spot on there.
People who are runners, for example, and they say, every time I run, I get a headache. And I say, well, drink 3 times the water you think you should, and this time they get through it without inducing their migraine. Lack of exercise. So couch potatoes have more migraines than people who are active. And getting up and getting out is a way to begin to reduce migraines. Along those same lines, having a few extra pounds on us is an independent risk factor for migraine. So we should all keep our weight at ideal, body mass index. Migraine sufferers need to do that even more. So these are some of the common triggers. And what we do is we run through a list and we say, do you have these? Do you have depression? Another risk factor.
Yeah, you have an impressive headache survey. I've seen it.
Yeah, right. It's you have to dig a little deeper.
Patients pre-populated before they see you.
Exactly, and we have a dedicated headache nurse at the Headache Center who's done headache for 20 years and knows it better than most doctors in the state, I think. So with her, what we do is a team approach, and I think that's a big buzzword in medicine anyway, which is to have a number of experts in their field, nurses, acupuncture, neuropsychology, therapists, all working with the patient. And the goal is this. This is the goal. Of course, you could say we want to stop their migraine. But, just like other chronic medical conditions, we don't cure it. But what we want to do is prevent disability. So what is disability? It's missing something. It's missing work. It's missing school. I've got 9th graders who have missed their entire year with every single day headache. And, we want to get them back to school. We want to get people back to work. And we want to give them the tools so that they have a toolkit at home so that when they get a migraine, which is hopefully rare if you've been to the headache clinic and I've done my job properly, but if you get one, you know the right medications to take in the right order, and you get your headache is now a 20 or 30-minute phenomena, not a 4-hour or 72-hour problem.
It was interesting. You talked about how it could impact and being disabling, whatever. And I recall a patient saying, I am a social cripple because of my headaches.
Right.
I go to work, I do the things I have to do. I have to do those. I have a family to support, I'll fight through it. But if I have the opportunity to go home, I don't want to go out because my headaches are there. I try to go into a dark room, I tried to rest. So again, it's crippling from that perspective. It's disabling.
And here's what happens. If you have a lot of those days per month, or every single day, every single working day, you get withdrawn and isolated from your family and your friends. And you know what happens with that? Yeah. It just makes things worse. So, we actually encourage patients, even if you can push it a little, to get out and do 1 or 2 enjoyable activities a week just to get the brain basically happy. There is a new concept in treating chronic pain, and it's called neurohedonism. That is, we have studies looking at brain chemistry where if you do things that are pleasurable and fun, your pain centers actually shrink a little bit. They get smaller. And so people who have chronic pain tend to isolate, withdraw, be by themselves. They get depressed, they get down, and what you've got is this positive cycle of misery.
I hear you, and it's fascinating what can be achieved with biofeedback and changing the environment. Okay, I told you I would be giving you some telephone numbers. If you want to reach out to Dr. McAllister, his telephone number is 203-333-1133. That's his office, and you can reach him at P. McAllister. That's PMCALLISTER at ANSC Neuro, NEURO, all one word, .com. So ANSCneuro.com, and that's how you could reach him during the day, and he'll respond to an email, or someone from the office will.
And the other kind of high-techy thing that I'm getting into more and more, Frank, is Twitter.
Okay.
So if those of you who are into Twitter, it's at drpetermca.
Okay, drpetermca. All right, if you want to join us right now, tonight, here in the studio, please pick up the phone. Give us a call. I'm sure there are several listeners out there who, unfortunately, are plagued with migraine headaches. Our telephone number here is 203-333-9422 or 1-800-922-6060. We'll be right back after this short break.
The hands at St. Vincent's are special. They've lifted patients whose hearts are on the mend, reunited families, and given hope to those who had none before. And now, working with the minds at St. Vincent's, they're finding safer ways to repair ailing hearts, like pioneering new techniques in minimally invasive cardiac care, so these hands can touch your heart, while these minds develop ways to make it stronger. Find out what gentler hands and sharper minds can do for you at stvincents.org. The minds at St. Vincent's are extraordinary. They've found new paths into the heart that others have missed. And with the help of skilled hands, they've orchestrated a symphony of doctors to keep an inoperable heart beating. Together, they're innovating cardiac care, making us one of the area's safest hospitals. So these hands can continue to protect hearts, while these minds continue to inspire them. Find out what gentler hands and sharper minds can do for you at stvincents.org.
Attention taxpayers. If you've received a notice from the IRS or state, do not ignore it. It's also a big mistake to try to handle your tax problem on your own. If you owe back taxes, it's a fact the government has the power to take everything you own, including your home, business, wages, savings, and your freedom. This tax hotline will help tell you about new programs to help you dramatically settle, reduce, or eliminate what you owe. But you have to call now. Take down this number or put it in your cell phone. But call 1-800-597-4977. That's 1-800-597-4977. When you call, you'll get free information on how you can reduce or eliminate back taxes, including penalties and interest. You can also be helped if you have unfiled returns, a tax lien, wage garnishment, bank levy, or if you have entered into a payment plan but can't make the payments. Don't make the big mistake in thinking you can ignore or handle your tax problem on your own. Stop the collection process immediately. Call this special tax hotline today for free info at 1-800-597-4977. That's 1-800-597-4977.
This is WICC 600.
Good evening. Once again, welcome back. And let me reintroduce our guest, Dr. Peter McAllister. Dr. McAllister is a neurosurgeon, and he is known as the headache specialist. He has a headache clinic. He has really worked very hard over the years to offer services that are quite unique to his practice and really provide population management for headaches. You know, that's the buzzword these days, population management. How do we take care of the issues within our community, and certainly migraine with, you said 36 million migraine sufferers?
36 million, right.
That's a lot. That's a lot.
In fact, there's a national campaign called the 36 Million Migraine Sufferers, and it's spearheaded by Cindy McCain, John McCain's wife. And she spoke to us at a big headache meeting and said that when he was on the presidential trail, half of those days she was throwing up on the airplane when they landed on the tarmac. So she knows firsthand the disability of migraine.
Let's talk a little bit about treatment of migraine, Pete. Now, when I went into private practice many years ago, probably at this point it's over, close to 30 years ago when I went into private practice, the choices, if you will, for treatment of migraine weren't a lot. In fact, it was kind of at the point where we were looking at medications that had already been developed for other uses and to see if they had any promise or they were applicable to patients suffering from migraine. So let's have you, the expert, give us a little tour down treatment lane here for migraines.
All right. So step one down treatment lane is a bit of what we talked about, so I won't go into it much again, but it's trigger identification and getting them to get into the right lifestyle habits, sleep and food and diet and fluids and all those things. So we'll put that all aside for a second, but that's hugely important. So now we get to medicines, and we divvy those up into two major flavors. The first is a daily medication you take every day, whether or not you have a headache on that particular day. And the goal of that is to decrease the number and severity of headaches. For example, Frank, let's say you had 17 migraines and you came to see me and I put you on a daily medication. The following month, instead of 17, you might have 11. And the month 3, you might have 6. And the following that, you might settle down around 2 or 3 headaches. So we've improved you. And then you can take a medicine specifically for those when it happens. So those are called daily or prophylactic medications. And as you said, you're right. They were often medicines that came out for other conditions. Certain blood pressure medicines are good at knocking down headache number per month. Certain seizure medicines, Topamax, people may know Topamax because it's pretty popular, decreases migraines. Calcium channel blockers, certain antidepressants, not all, but certain subclasses, amitriptyline being a common one. So these are medicines that we put people on if they're having a frequent number of headache days per month, more than about 5 or 6. And we usually keep you on it for 2 or 3 or 4 months. If your headaches go down and melt away, we then try to wean you off because we really try to be medicine minimalists. We get rid of decrease the number, decrease the disability, eliminate you from not going to work or not going to school, and then try taking you off. Now, when you get a particular migraine, we also give you medications that are the knocker-outers. These are the abortive medications. The most common class that seems to be very specific are the triptans, and people may know Imitrex, which is sumatriptan. It came out initially in the 90s as a shot, and now there are pills and nasal sprays. So that's a big class of drugs that we use so that you might be on a daily medication, and then when you get your migraine, you might take these. You have to take them very fast in the headache cycle as soon as it starts, and success rate is in the 60-70%. So there are some vitamins and supplements, magnesium, vitamin B2. There's a supplement that's common in Europe that we're using here called Butterbur. So a combination of daily medicines in the right individual, knocker-outers that are specific for migraine, and then supplements and some dietary modifications is what we do as our first run for treating migraine. If you have this condition called chronic migraine, so these are the 15 or more headache days per month. This is the worst of the worst group. There's only one drug that's approved by the Food and Drug Administration, and it may surprise some of the listeners to know that medicine is Botox, which is used cosmetically. It's what the models and the actors and actresses all get, but it was found by accident that if you inject Botox in and around the head, neck, shoulders, etc., you can decrease the number of headache days per month substantially. So we do a fair amount of that over in the practice in Fairfield.
And one of the things that I'd like to talk about, and I know it can be a slippery slope, but I'm just want to talk in a very broad terms, medications that individuals take. You talked about being a medication minimalist, but yet polypharmacy is truly more prevalent than the minimalist approach. Patients see several doctors, several specialists, and oftentimes they see them in silo. This is hopefully what the electronic medical record will do away with. That type of silo treatment will be communicating better. But they get this pill from that doctor, which they neglect to tell, their primary care, or they neglect to tell the neurologist. And yet some of these medications, when you look at potential side effects, and we all appreciate that, they really disclose a wide variety of potential issues and side effects, and some never are a player or never come to fruition, but a lot of them list headaches. In your experience, have you seen headaches brought on by other medications?
Yeah, but not usually migraines. So there are certain heart medications, the nitrates that are classic for it, some blood pressure pills, certain calcium channel blockers. I had a dentist who came to see me and out of the blue developed an everyday headache, and we couldn't figure out what it was until I said, you know what, let's try stopping a few of your meds and see what happens. And we stopped his cholesterol drug, Lipitor, and his headaches melted away. And lo and behold, you look up the side effects of Lipitor, and before the liver trouble and muscle condition that we associate with Lipitor is headache. So you're absolutely right, Frank. And sometimes patients neglect to tell us. One that they commonly neglect to tell us is birth control pills. All right. So some women actually, their headaches get better on birth control, but some actually worsen quite a bit, and they forget to mention it. Here's another one, another group of medicines that patients often forget to mention, the over-the-counter pills. So let me tell you a little story about Excedrin and all the subtypes of Excedrin. Excedrin migraine, Excedrin tension headache. I only half-jokingly say that those medications are really good for my business, and I'll tell you why. If you have a headache once or twice a month and you pop an Excedrin, it's a pretty effective, inexpensive, over-the-counter medicine. But here's what happens. In most people, if you take more than 2 days a week of Excedrin, and I've got some patients who take it every single day, what happens is you build up a blood level of Excedrin, and then when you don't have it for a bit, you withdraw. And what happens when you withdraw? You get a headache. And you wake up with this splitting headache and you say, what's that medicine I used to take that helped me? Excedrin. And there goes a cycle of just feeding your withdrawal, much like a heroin user would use heroin to get high, but then really they're only using it to prevent the withdrawal.
It's almost a rebound phenomenon.
It's exactly a rebound phenomenon, Frank. And that cycle has to be broken. And sometimes I say, do you take any medicines? I say, no. I said, you take nothing? Well, some over-the-counter Excedrin. Well, how many Excedrin do you take a month? And they add it all up, and their fingers and toes, etc., and they say 72. They say 72 pills a month. And then I quote them a famous study from a guy named Richard Lipton at Montefiore down in New York City, where he did the work, and he found that 6 or more days of Excedrin use per month can cause this rebound headache. So sometimes taking away pills winds up being the best way to get them out of that cycle.
And what is it in the Excedrin that's usually causing?
So that's a very complicated question that we don't have an answer to. Okay. Certainly caffeine is a double-edged sword, and Excedrin has caffeine in it.
Right.
Again, if you take 4 aspirin and a big cup of black coffee, you can knock out your migraine. But coffee even every day can lead to a caffeine-induced headache. So, I say to my migraine patients, try cutting down to 1 cup a day. And then if they're getting a little better, I say, why don't you try eliminating it for 4 to 6 weeks and see what happens? And some folks get better when they take away their coffee.
Other common triggers that you would identify?
So here's another interesting one, barometric pressure.
Barotrauma.
When the weather gets cloudy and a big storm is coming in, that's when my migraine sufferers call. In fact, we're publishing a study where we looked at, now Frank, we have at our center what we call drop-in headache clinic. So if a patient has a bad one, they've tried their medicines at home and this time it didn't work, they can come in without an appointment, we get them set up, we put an IV in them, and we knock out their migraines. So we're looking at the visits to the drop-in clinic as it relates to weather patterns. And preliminarily, I can tell you, when the weather changes from high pressure sunny to low barometric pressure rainy, that's when people come scurrying into our center.
I had a similar conversation with an orthopedist years ago, and he shared with me several sites on the internet that are, I can't remember the exact, but they reference and deal with barometric changes, barotrauma, based on the findings of orthopedic complaints, bony musculoskeletal complaints. And I went on the website at the time, and I was totally impressed with the correlation. And, it's interesting to hear you say now with the migraines.
We are very sensitive to our environment, sometimes more than we'd like to believe. Migraine sufferers seem to be a little more sensitive to the world genetically than non-migraine sufferers. That's why sleep disruption, a drop in their blood sugar because they skip breakfast, dehydration, they feel it more than us, and it triggers their migraines.
I had a patient who dreaded to fly, not because he was afraid of flying, but he told me every time on descent he would get sharp pains in his head that led to a migraine.
Yep, absolutely. The small barometric pressure in air travel can also be a big trigger in these very sensitive people. Migraineurs are a little different.
Okay, we're speaking with Dr. Peter McAllister, who is a headache specialist, neurologist, board certified in practice at the Associated Neurologists of Southern Connecticut. And if you'd like to speak with him this evening, question or comment about headache, please pick up the phone. It's 203-333-9422 and toll free 1-800-922-6060. We'll be back with more of St. Vincent's Health Talk and Dr. McAllister right after this.
The hands at St. Vincent's are special. They've lifted patients whose hearts are on the mend, reunited families, and given hope to those who had none before. And now, working with the minds at St. Vincent's, they're finding safer ways to repair ailing hearts, like pioneering new techniques in minimally invasive cardiac care, so these hands can touch your heart, while these minds develop ways to make it stronger. Find out what gentler hands and sharper minds can do for you at stvincents.org. The minds at St. Vincent's are extraordinary. They've found new paths into the heart that others have missed. And with the help of skilled hands, they've orchestrated a symphony of doctors to keep an inoperable heart beating. Together, they're innovating cardiac care, making us one of the area's safest hospitals. So these hands can continue to protect hearts, while these minds continue to inspire them. Find out what gentler hands and sharper minds can do for you at stvincents.org.
Hello. Eyes on the road, I'll talk, you drive. Just wanted to pop in to remind you that every Honda certified used car comes with an outstanding limited warranty. And you know what they say about outstanding limited warranties. They're outstanding. Anyway, just letting you know in case you were thinking about upgrading. And if you're not thinking about it, you should be. Honda certified used cars are awesome. And you do like awesome, don't you? Of course you do. Because you're awesome. All right, I'm out of here. Oh, and see your Honda dealer for limited warranty details.
Dad, what are you doing in my cape?
I'm not Dad. I'm Safety Man.
Any parent can be a safety hero. It just takes a few simple steps. Start by replacing older smoke alarms with Kidde Worry-Free alarms. The 10-year sealed-in lithium battery means these alarms are always on. No low battery chirps and no battery replacement for 10 years. And Kidde makes it simple to choose the right alarm for the right location. Help make fire safety worry-free and give back the cape. Kidde Worry-Free alarms. Available at the Home Depot.
Named the best local talk station by Fairfield County Weekly. You're listening to WICC 600.
Good evening, and thank you for joining us this evening. We are entering our final segment with Dr. Peter McAllister, who is a headache specialist, a neurologist, board-certified neurologist, and he's here tonight to share his expertise on the topic of headache. Now, Peter, we talked a little bit about treatment, and is there anything exciting coming down the line in terms of migraine treatment? Are there any studies out there, any drugs look promising, any therapies, any modalities of treatment other than drugs, medication?
Yeah, actually, the last 10 years have really been the decade where we figured out this black box that was migraine. We kind of know what's going on now, what chemicals are being released, what hormones are misbehaving, and now we can target specific therapy. So I think no longer will we just sort of stumble upon a medication that turns out it works in migraine, but we're having specific drugs. And one of the things I do at the center is I direct our clinical research. So I'll tell you briefly about one very exciting study. It is a specific new, what we call monoclonal antibody. That is, it is targeted. One end of it is like a lock and key to fit into one particular area of the brain, which is called CGRP. CGRP is a bad guy in migraine. It starts the cascade. So this is a shot given once a month that goes up to the brain, hits CGRP, and turns it off. We think that, and again, this is a research study, but smaller studies in humans and certainly the animal studies have shown a tremendous decrease in the number of migraines with a very targeted, what you might think of as a smart bomb. And so if anyone has migraines and might be interested in participating, the downsides of being in a study is this is a 1-year study, and for the first couple of months, you might get a shot of the real medicine or you might get a shot of water, and that's what we call a placebo. After a couple of months of that, everybody gets the real medicine for the next year. So it's a very exciting time with that study at our center, as well as some interesting stimulators that you can put on your head or neck and turn on an electromagnetic current to try to drive down your headaches. So we have studies in those as well. So if anyone's interested, feel free to contact me. I'm sure you'll give out those numbers one more time.
Okay, another cause, if you will, for headache can be post-concussion. Now, we're in football season at every level. Pop Warner, high school, junior high school, college, pros. And we see a lot of really high-impact hits. Now, they're trying very hard to modify and change behavior of the players on the field to emphasize that that type of an injury is not good. It needs to be avoided and can be avoided, but sometimes it just happens. Talk with me a little bit about concussions and headaches associated with concussions. So
that concussions have been really big in the news lately, particularly with a lot of this stuff about the NFL and what did they know and when did they know it, etc. A concussion is an injury sustained to the head or even a hit to the body that the head, sustains some trauma. The brain inside the skull jiggles, actually, because it's got the consistency, if you will, of jello, and it's surrounded by fluid. So what happens is there's small ripping and tearing of the connections from one nerve cell to another. People with concussion have headache, and that's, why what sprang out of our headache center was a concussion center, but they also have vertigo, they have mental slowness, fogginess, their balance is off. So this can last a week or two, or it can last 6 weeks or more. We take care of school-age athletes, college athletes, and people who have had concussions that don't relate to sports at all. And I tell you, when they are hit, unless they take care of it properly, they can really prolong their agony. So when they come in, we do a brief sports-based neuropsychological test to find out how bad their brain got slowed down from this thing. We then examine them to make sure there's no dangerous signs. Again, like migraine, 95+% of concussions don't need a CAT scan or an MRI. The diagnosis is made clinically by the symptoms, by really listening to the patient and examining him or her. The best thing you can do for a concussion, and we have to emphasize this, it's hard to do, is rest. So you stop everything, you don't multitask, you barely single task, and you give your brain time to heal, and you stay hydrated, use nonspecific medicines for your head pain. This could be ibuprofen or Aleve or Tylenol, and it's a lot of watching and waiting. And we retest you every couple of weeks to see whether the brain function is returning to normal. Because the last thing we want to do, particularly in school, is send a kid back to the football field or to the soccer field before their brain is fully healed up. We know that people who get a second concussion in short order are really at risk of doing some perhaps permanent damage to their brain.
Yeah, I think that's the real concern, and I do have to commend present efforts. Certainly for many years it wasn't high up there on the priority list to address, but recently, there's all kinds of education requirements for coaches, for referees, for those involved in sports, contact sports particularly. But you're right, that type of protracted exposure to head trauma can really take its toll, particularly in an aggregate fashion.
Right. And, the head pain that comes after it can then evolve into a migraine. And it's interesting if you have, say, a 12-year-old who had a lacrosse based concussion, and we see them and the concussion symptoms go away, but now they're having 2 or 3 times a month nausea, light sensitivity, throwing up, headache, missing school. Oftentimes, if you ask mom or dad if they had migraines, the answer is yes. And what happened in this case was the concussion brought out the migraine. So, again, when we listed lots of triggers, well, having a head injury, having a concussion is an independent risk factor for generating headaches that stay with you.
Interesting. You're doing some work on concussions at this point, too?
We're doing some research on concussion, and we're about to get a whole lot more interesting things. So stay tuned and have me back. We're looking at some novel ways to stop concussion sooner without just having to watch and wait.
That's pretty impressive. I want to be certain that our listeners, because headaches are such a problem, concussions are such a problem, I want to be certain they do have some contact information for you. Now, I've given it, but I'm sure you'll do a much better job. How would one reach you if they choose to discuss headaches or concussions or look into some of the modalities you've talked about, the research and all?
So the phone number at the practice is really easy. It's 203-333-1133. So nice and easy. The email, as you mentioned, which is pmcallister, MCALLISTER, at anscneuro.com. And again, Twitter is at drpetermca.
Peter, are you accepting patients into some of these studies at the present time? Are they full?
The studies are open. We've got a number of studies that open and then close, so there's always a few headache studies. In our clinical research center, we are doing novel Alzheimer's studies. We have multiple sclerosis studies, Parkinson's and seizure studies. But as the headache specialist, I'm running the pediatric and adult headache studies.
And in terms of these studies, you say that there are medications that are actually being delivered versus placebo, but then you transition everybody over to the actual medication to see what the end result is.
It depends on the study. The study design is worked out with the Food and Drug Administration, the sponsor company, etc. But, the vast majority have what we call a double-blind period that can last weeks or months, where you're either going to get the real drug or an inactive drug. If it's a pill, it'd be called a sugar pill. If it's a shot, it'd be a shot of water, or just we call saline. But then almost all the time there's what's called an open-label phase. It's basically the reward, I like to say, for being in the part where you weren't sure what you were getting. And then that will go on for months or a year, or some studies are 2 years, in which we collect further data on the safety and how it works and whether you liked it and how your quality of life changed, etc. We've been doing research at the center for over 15 years, and we've seen some really fascinating products come out, not just in the migraine realm, and we're working on some really exciting sort of first-in-class game changers. For example, if you have Alzheimer's disease, there are 4 drugs that slow down the process, but we have nothing that takes it away. So we're looking at a medicine that's given as an IV infusion. This goes up to the brain and actually pulls out the plaque. So in Alzheimer's, there's this stuff that gunks up the brain cells called beta amyloid plaque. And this medication pulls it out. And we're hoping, and we've already got some signals because we've looked at some of the data already, but we're hoping that this may not just be something that slows the disease down a little bit, but we're looking to stop it in its tracks, or the Holy Grail is to reverse some of the changes. And that's why clinical research is very exciting. For me, it gets new medications to patients who need them. It's exciting. It's state-of-the-art, and we try to be as on the cutting edge as possible. For the patients, it allows them to try something new. If they don't like it or aren't happy with the study, they're welcome to withdraw. There's no arm twisting, so it's certainly all voluntary. The studies are free. Nothing goes through insurance, and any procedures that come with the studies, whether it's an MRI, an EKG, a blood draw, all of that is free as well. So it's a nice way to get involved in not just helping yourself, but getting new medications out there for all the other people in this country who are kind of looking for more options.
And all of the drugs that are in use today went through a very similar process in terms of being validated for their use and safety and efficacy.
It's kind of fun and rewarding to see some of the medicines that we at the center worked very hard on become FDA approved and get out there. Probably 90% of what we've done has ultimately gotten approved, and about 10% they looked at the study and they found either there was something they didn't like about some safety feature, or it just didn't work much better than placebo. So 90% is not bad.
Well, Dr. Peter McAllister, let me thank you for coming down this evening and lending your expertise to St. Vincent's Health Talk. Our listeners, I'm sure, enjoyed it and got a tremendous amount of valuable information from our dialogue.
Well, it's a
At
lot
least
of
I
fun.
hope they did.
Thank you, Frank.
And
It's a lot
we
of
always
fun.
want to educate. So until next week, I'm your host, Dr. Frank Schifo, wishing you good night, good health, and may God bless. Health, and may God bless. Health, and may God bless.